Hello, everyone. My name is Samantha Bunsley, and on behalf of the OPUS Education and Training Committee, I welcome you to this bi-monthly OPUS webinar series. I would like to begin by paying my respects to the traditional custodians of the land on which I am zooming in from today, that's Jagera country, and the lands on which you are zooming in from, right across Australia, acknowledging that sovereignty across Australia has never been ceded. I would like to pay my respects to the elders past and present of these lands and recognise their continuing connection to land, waters and community. I'd also like to extend this respect to any Aboriginal and Torres Strait Islander people who may be in the audience with us today. Now, it's my pleasure today to introduce Dr. Ruby Biezen. Ruby and I go back a fair way to when we were fledgling researchers at Monash. I remember getting together a group of friends to participate in a focus group for Ruby's PhD. And that was exploring knowledge and attitudes of parents on the management of respiratory tract infections in young children. So I remember that being a very fun evening, Ruby. Ruby is currently working as a research fellow at the University of Melbourne Department of General Practice on projects to reduce inappropriate prescribing and antibiotic use through developing clinical decision support tools for GPs, developing information sheets for patients, and educating children in hand hygiene through gaming. I invited Ruby to come along to share her research with us today, given our own activities at OPUS developing clinical decision aids, education resources and communication strategies in the context of joint replacement surgery. Now, regarding the format for today's session, we're going to hear from Ruby first, and then we'll have a Q&A session at the end. Your videos and microphones have been turned off, but to post your questions, please use the Q&A box. Or if you'd prefer to ask your question out loud during the Q&A, then you can raise your hand and we will unmute you. And Ruby, before I pass over to you, I just want to thank you in advance again for your time speaking with us today. I know you're really stretched for time at the moment, so we're really grateful for this opportunity to hear from you. Right, I will stop sharing my screen and pass over to you, Ruby.
So thank you so much, Sam, for that warm introduction, and we do go a long way, but I won't say anything to incriminate either of us at the moment. We can do that after our session if anyone else is interested about how we used to run our wonderful sessions at Monash University. So thank you so much for the invitation and the warm welcome. So I just want to share some of our recent work on shared decision support for patients on antimicrobial stewardship strategy to promote appropriate antibiotic use in primary care. So antibiotic resistance is a threat to global health. Australia is one of the highest prescribing countries in antibiotic use per capita, at double the rate of the lowest prescribers such as Sweden and the Netherlands. The vast majority of antibiotic prescribing in Australia happens in primary care, so it's really important that stewardship strategies are identified within this context. Inappropriate antibiotic use, so where antibiotic prescribed is incorrect for the indication, antibiotic prescribed duration was too long, too short, or simply not needed, is associated with the promotion of antimicrobial resistance. This poses immediate long-term and short-term threats to human health. So developing tools such as patient information resources containing relevant information to assist patients to understand their conditions and encouraging communication with the healthcare providers may reduce inappropriate antibiotic use and guide care decisions to help ensure that management meets the patient's expectations and health outcomes. Co-designing these informations with healthcare providers and patients or end users may actually increase their acceptability and usability. However, the current patient information sheets and resources haven't really been developed with end users in mind and filled with lots of information, difficult for layperson to understand and not tailored for the target audience. So the aim of these studies were to develop patient information sheets on common infections using a co-design methodology with healthcare providers and consumers, and then to pilot these informations across general practices for their acceptability and usability in primary care. So therefore, the first part of the study that I'd like to present to you is how we develop patient information resources using a co-design methodology. So the co-design session consists of 3 meetings conducted between October 2019 to March 2020. So we recruited participants, including 3 GPs, 1 pharmacist and 1 practice nurse. We also recruited 6 consumers, including 2 elderly participants, 1 dad, 1 mum, a single male, and a 19-year-old male. So in the first session, we focus on what information that participants consider as important, what delivery modes they thought were acceptable for patients by conducting these 5 activities. So we'll discuss these a bit more in the next few slides. So at the first co-design session, we firstly discussed with the participant some of the common areas in patient information sheets. So for example, the definition and the course of the disease, the natural history, what are the common symptoms, and the management options and prevention strategies, risks and benefits of antibiotics, what are the danger signs to look out for, the complications, and when to see your GP. So we asked participants to rank these categories from 1 to 11. So we want to know what information is important to you as a healthcare provider and to your patients, and what are these that are important to you as a patient. So next we gave them 5 common patient information sheets that are different in type, style, and then we asked them to critique them. And then we also asked them what they liked and didn't like about these information sheets. So after a roundtable discussion, we then asked them to rank the 11 categories again from 1 to 11. So let's have a look at the results from these activities. So for healthcare providers, when to see a GP was the most important information that they said needed to be on the patient information sheets before and after critiquing these information sheets, while the risks and benefits of antibiotics was seen as the least important. Before critiquing the information sheet, consumers actually wanted to know more about the definition and the management option of the disease. However, after the activity, they actually thought that information sheets should include common symptoms and natural history of the disease were considered as much more important. Prevention, surprisingly, was least important in both. So to compare what healthcare providers and consumers consider as important, while when to see a GP was rated as the most important area for healthcare providers, for consumers, it was actually ranked in the middle before, and after looking at the patient information sheet, it actually ranked a lot lower. What is really interesting is that us as healthcare professionals working in the antimicrobial stewardship space, we actually all thought that risk and benefit of antibiotics would be important to include in patient information sheets. But however, looking at these results, neither the healthcare providers nor the patients consider risk and benefit of antibiotic was high on their list. So the exercise actually showed that healthcare providers and consumers not only prioritise information differently, but us as researchers and healthcare providers thought that end users may want. It's not necessarily the case. Therefore, it demonstrates the importance of any tool development should include a co-design process centred on healthcare professionals and patients who are actually your end users. So we also in this session asked participants what type of information they think it will be beneficial for before, during and after consultations. So here are some of the suggestions from the participant session in the co-design meeting. So taking the information from the co-design session 1, we went to the drawing board and mocked up some content information. We took this to the content expert group consisting of GPs, pharmacists, nurses, and microbiologists. We then developed the first prototype of the information sheet with the graphic designer, as you can see on the left. So then we brought this back to the co-design session 2 to the same participants, and we focused on the format layout of this prototype in colour and also in black and white format, because we can't actually expect GPs to always print these out in colour for their patients. So they do have to look good in black and white. And then we further developed the content. So this is what we did in terms of content. We just put all the information in. We cross-checked it with therapeutic guidelines, which is our national endorsed guidelines. So after session 2, we went back to the graphic designer, and depending on what we wanted to do, we changed the format of the information sheet again. So in co-design session 3, it was scheduled in March in 2020. Unfortunately, a lot of you would have remembered that COVID hit, and we had to cancel the face-to-face meeting. So we converted the session to sending coloured and black and white copies of these information sheets, and asked all our participants to critique them by marking up the hard copies as seen here on the left, and we get them to send it back to us. We also conducted interviews with these participants via phone or Zoom, exploring their thoughts on the final design, layout and content, as well as possible delivery mode and access of these information sheets. We're actually really surprised how adaptable and flexible our research was. Thanks to the engagement of all our participants, we had conducted 4 interviews and received all marked up copies within 3 weeks. So here are some of the results from our interviews. So we were able to group their qualitative responses into 6 themes. So content of the information sheets and communicating the information to include the lay terminology and personal inclusive language. The design of the information sheets and the type of delivery and access for before the consultation, during and after consultation, and whether it should be in paper format or accessed online. And we also looked at how these information sheets should be used and whether it is actually usable, and how to use these tools to engage patient and healthcare providers to have the conversation around management, in particular the use and benefit of antibiotics for their particular condition. So in terms of information content and communication, it needed to be simple. It should be relevant and helpful, clear and easy to communicate to the patient. So for example, this healthcare provider said they'll be useful way of being able to explain why the person doesn't need to have antibiotics. The information sheets need to be easy on the eyes and able to highlight important content to make it easy for patients so they're not searching for relevant information. It should be easily accessible, mainly as a printout, during consultation to encourage that conversation between healthcare providers and patients. It should be user-friendly for both healthcare providers and patients, and engaging to patients that they're comfortable to have the conversation with not only the healthcare providers, but also with their families and friends. So overall, from this 3 co-design session, the main take-home messages for us while developing these 2 tools are as follows. So it should be communicated in a plain, concise and logical manner, using inclusive and simple language, and developed to a grade 5 reading level. It should not have information that is confusing for the audience, your patients. It should be single page, A4 size, with bold heading and short description, appropriate for use before, during or after consultation. So from the co-design session, we developed 7 patient information sheets, included acute bronchitis, tonsillitis, otitis media, rhinosinusitis, acute cystitis, cellulitis, and leg ulcers. So these information sheets are simple, consistent across all the spectrum of these conditions. They're tailored for the layperson and language consistent to a grade 5 level with bold headings and a balance of illustrations and words. Importantly, we were able to incorporate all 11 categories that we talked about earlier to these information sheets, and they've all been cross-checked with therapeutic guidelines for accuracy, making these patient information sheets evidence-based. So in the study, we used a co-design methodology and were able to provide a collaborative forum with a diverse group of participants to systematically design and develop products that are acceptable and meet the needs of both clinicians and consumers. Even though there were initial dissonance between primary care providers and consumers in the co-design sessions, but over the course of the 3 meetings, they were able to come together and assist in the development of patient information sheets to produce something that is visually appealing, consistent in style, formatting and messaging, and appropriate for use for each of these 7 conditions. So the next step is to pilot these information sheets across general practices in both metropolitan and rural Victoria to assess their usability and acceptabilities, and this will be made available more broadly after further revision. So that takes us to the next study, which we piloted these patient information resources across 8 general practices. So healthcare providers from each of the 8 general practices across Victoria were recruited through the Department of General Practice, the Victorian Primary Care Practice-Based Research and Education Network that we call VicREND. During the study period between 3rd of August and the 30th of November, we asked participating GPs to use the patient information sheets with their patients who attend the practices with symptoms of respiratory tract infection, skin and soft tissue infections, or urinary tract infections where appropriate. So healthcare providers from each of the 8 participating practices were invited to participate in an interview to discuss the acceptability and the usability of the shared decision support tools. So patients from these practices who attended the practice with the common infections were also invited to participate in an interview. So interviews were conducted between October 2020 to March 2021. So here are 2 of the 7 patient information sheets developed using the co-design process in case you've forgotten already. This explained the disease, the symptoms, management and prevention, antibiotic use, and advice to whether they need to see a GP. However, due to the COVID pandemic, we added a link to the Victorian Government website on COVID-19 on all respiratory information sheets. We then provided all practices with a link to the 7 patient information sheets online. We also sent them electronic copies of these resources with instructions to save onto their computer desktop for easy access, and we sent them colour hard copies to use with their patients where appropriate. So 8 general practices including 4 metropolitan and 4 rural practices were recruited to the study. The number of GPs ranged from 6 to 15 in metropolitan practices and 4 to 11 in regional practices. We had 14 GP and 1 practice nurse participating in the interview. Of those, 2/3 were in the 31 to 50 age group with an average of 15.75 years of experience in the GP group. We had a total of 13 patients participated in the interview. There were 8 females and 5 male. Majority of them were in the older range. However, we were able to capture patients across the whole age spectrum. 6 of these have an undergraduate and postgraduate degree, 4 with trade certificates, and 3 had high school level education. We had wanted to recruit patients in practice waiting rooms. However, once again, due to the pandemic and the lockdown restrictions, we had to rely on practices to recruit these patients for us. However, after the second lockdown, late last year, and the easing of restrictions, we were able to recruit patients directly at the practices. So 5 patients were recruited by the practice and 8 by the research team. So these are the themes that were identified in the 28 interviews. Starting from the top left, the themes were the drivers for the use of information sheets, content, communication, design, delivery and access, usability of these tools, the engagement, cultural diversity, and the barriers to use these information sheets. So if you remember, the co-design session had the 6 themes. So these 3 were the new themes that came out of our patient and healthcare provider interviews. However, for the purpose of the presentation, I just want to highlight these 5 themes. So in terms of drivers for the use of information sheets, GPs expressed the importance of providing patient information sheets as useful and evidence-based information to educate patients about appropriate antibiotic use. Almost all patients commented that the information sheets were important to provide education around their diagnosis and how to self-manage their conditions. Important design elements such as bold text heading and balancing word with pictures were considered as important during the co-design phase. Similarly, the participants from the pilot phase also commented having bold text heading, straightforward question and answer format, simple sentence structure and eye-catching illustration, and meaningful pictures as important elements when delivering essential messaging to the public. In terms of delivery, participants were divided as to whether patient information sheets should be online for patients to access or as printout during consultations with their GP. Having easy online access and not able to have printout due to telehealth consultation were reasons for having online access. However, we found that with older patients with minimal or no online access and the ability to have a copy in hand were reasons for having printout of these information resources. So in general, having the ability to access information online as well as printed copy available were considered as best options moving forward. So during the pandemic, patients with respiratory symptoms were sent to respiratory clinics. Hence, GP didn't really have many opportunities to use the respiratory patient information sheets. While the patient information sheets were not used as intended during the pilot phase, patients who were interviewed thought the patient information sheet would educate patients around disease management and treatment options, as well as prevention and antibiotic use. They also thought they would encourage patients to see their GPs if the symptoms had not improved or worsened. And a barrier of using these information sheets during the intervention period include access and delivery of these information sheets. So GP recognised that some patients were not tech savvy and therefore it was difficult to deliver the information sheet by email or direct the patients onto the website to access their information. Hard copy remained the only option for these patients. However, this was difficult, as we mentioned again, that the pandemic changed the way face-to-face general practice consultations move onto a telehealth consultation. And majority of the patient with respiratory tract infection symptoms were referred to respiratory clinics rather than being seen in general practice. So this resulted in the patient information sheets not being used as frequently as they might have been. So our study demonstrated that a robust co-design process allowed participants from different backgrounds and professions to come together to understand key priorities and needs to work together to develop a product that meet the needs of both health providers and patients. We had a very minor change in wording, no format changes in the final product. Patients were overwhelmingly wanted information sheets that were informative, with information that include disease symptoms, what signs to look out for, prevention, management and treatment strategies, and when to see a doctor. They also needed to be simple, clear, with balance between word and pictures, and relevant to patient condition. The COVID-19 pandemic disrupted the project and restricted the use of these information sheets throughout the piloting period. We had to adapt to the way we delivered the project. However, healthcare providers and patient interviews reviewed that the information sheets were acceptable in both metropolitan and rural settings in Victoria, and participants were happy to use them and would continue to use them where it's appropriate. So finally, the project demonstrated that there is a place for patient information sheets to assist patients to understand their health needs. So what are the next steps for this project? So we can look into promoting patient information sheets across the Australian community. So these would include the Australian Government Department of Health websites, the Royal Australian College of General Practitioners, the Australian Commission on Safety and Quality in Healthcare, the Australian Primary Health Network, and also the Australian College of Rural and Remote Medicine. So we should increase the awareness of these resources through the community by advertisement in practice waiting rooms and posters in pharmacies and practice waiting rooms. We also would look at optimising the tool to facilitate access for both healthcare providers and patients. So this may include integration with existing guidelines, such as therapeutic guidelines, and also in health pathways. And we should also integrate into, where possible, electronic medical record systems and pharmacy systems. But what was really interesting that came out, the interview process, was that we should translate patient information sheets into different languages to facilitate the use in culturally and linguistic diverse patients. So I'd like to thank my team and the participants in the study. I'd also like to acknowledge our funders for their support. I'm happy to answer any questions. Thank you.
Wonderful. Thank you very much, Ruby. Do you want to stop sharing your screen then, maybe, Ruby, and then we can... Fabulous. Thank you. Well, look, I really enjoyed listening to that wonderful body of work that you have produced there. And I'd like to open the floor for any questions. So please feel free to type in your message into the Q&A box or to raise your hand. We've got Manny or Michelle there that can unmute you, and we'll just give people a moment as they trickle in, Ruby. But I've got lots of questions that I've been jotting down here as you've been talking, Ruby. One of my first ones is around, where shall I begin? What engagement was like amongst the GPs in your study?
They were actually really engaged. I think coming from the Department of General Practice, we have built continuous relationship with these practices, really helped us in our setting. So I think it's really important to continue building that engagement, whether the GPs or the practice nurses or the practice managers are conducting the research with you or not, or whatever time it is, you should always engage them. So that's why the engagement's really great. But it's actually shown with another body of work that we've been doing. The practice manager are your gatekeepers. So you need to engage them and keep them happy, and they'll make it a lot easier to have that relationship and to build your research profile with them.
Absolutely. So you were involving 8 clinics, is that right, in that final piloting phase that you did?
Yep.
Okay, and within those 8 clinics, the GPs were, what was the uptake like of use with the patients themselves? Were they using it with each patient that came through? Were you able to monitor?
Yeah, that's actually a really interesting question, Sam, because that was something we had hoped that they would do. But however, it was really difficult because of COVID and all the barriers that came with it, that, you know, because we had 4 of the patient information sheet out of 7 were respiratory infections or respiratory related infections. However, during COVID, as you know, with lockdown and everything, every time a patient had these symptoms, they would, you know, put through to the respiratory clinic rather than a general practice clinic. So what the GP has actually told me, or quite a few of them told me, was that if a patient came in with respiratory symptoms and they'd been referred to the clinic and then came to them anyway, they had to meet them outside in the car park with all the PPE. So what that means is they've got all their PPE on, they've got their swab, they've got all these other things. They couldn't actually think of carrying the information sheets as well that are relevant to them. So it became a little bit clumsy.
Sure.
So,
yeah. Trying to do this sort of research at the time of COVID, that's challenging.
Yeah,
I get
it is challenging. Yeah. However, we did count the number of views in, you know, with those 8 clinics. So those 8 clinics had the link to the information sheets, as well as the GPs have the option to give the link to the patients. We actually had over 850 clicks or views of these information sheets during the two to 3 month intervention. So excellent. Even with all the barriers, it wasn't that bad.
You're able to monitor some of that. Yeah, lovely. Ruby, we've got some questions coming in here. The first one from Dan Gould. So how did you facilitate the focus group, Ruby? I imagine it could have been tricky having consumers and clinician practitioners at the same group.
Yeah, so when I actually, thanks for that question, Daniel. Initially, when I put in the ethics application and I said, I'm going to have, you know, up to 10, 12 people in the same co-design or focus group session, one of the comments from other people as well as from ethics was simply put, are you crazy? You know, having the healthcare providers and consumers in the same room. The reason for us to do that was, it was important to me, because I'm not a GP or a medical doctor. I've got a background in microbiology. I've done research in this area, but I'm also can be classified as a consumer. So I understand that what GPs may not understand what we're trying to get across, and vice versa. So it was really important for us to bring them in the same environment. However, it was tricky at some areas, but they're all adults, except no, the 19-year-old one was an adult, I guess. They're all adults. They did. We did get into some pretty heated debates and discussion, but I had myself, my supervisors, we had other facilitators to help, you know, moderate the heated discussion. It was only heated because they didn't agree on certain points, like, you know, when to see a doctor or benefits or risks, but we're able to pacify them as we go. So that was really interesting.
Yeah, I was interested that some of those, the rankings shifted pre and post discussion. And so what was some of the, can you talk us through a little bit about how those shifted through the course of the conversation?
Yeah, look, it was, I don't know how they shifted, because, you know, initially I said to them, so these are different categories, and I explained what each category consists of. So what does it mean by the natural history of the disease, and what does it mean by disease and all that. So when they ranked them initially, of course, I know the healthcare providers are quite used to these terminologies. Maybe the consumers weren't. So we're explaining to them was really useful. But when they actually look at the 5 different sheets of information sheets around, you know, antibiotics or bronchitis or anything, and UTI, they look at, and I highlighted each category on these sheets, and we actually came together and we discussed them in depth of what they like and dislike about, you know, certain things. No, too many words, too much information, this and that. And the perspective changed, and that was really interesting to see what was then classified as more important to them. Because when you bring them together and they see that it's too much information, then in their mind they have to then say, well, what is more important to put in the information if we can't have certain things? So to them, I think they were negotiating within themselves to get that data. But that was really just wanted to show you what we think as researchers may not be what the end users think, and the importance of including them, because ultimately they need to use it. If they don't use it, we've wasted all our time doing the work.
Yeah, no, absolutely. Ruby, another question here from Penny. Did participants suggest any formats other than patient information sheets?
Yes, they did, and it's not like we didn't listen to them. We did listen to them, but we just in the time and the capacity, we weren't able to do it. So other formats that they think will be really good was like little what they call those advertisements that comes through. Yeah, little videos and things like that. They talked about games, which is really something I'm really interested in. So games that, you know, kids can play with, you know, simple games that kids can play with, you know, on the iPad or on the phone or something that, you know, they can understand about, you know, things like disease symptoms or coughing and etiquette, you know, and prevention. So things like that we also talked about as other formats. But patient information sheets, in the co-design session, the participants realised how little we have currently, and the ones that we have are not always applicable to use within the primary care environment.
Yeah. One of the things that we're seeing in our research, Ruby, we're doing some work with Aboriginal and Torres Strait Islander communities, and one of the things that we're hearing about as far as the delivery of information is the power of little videos, and people have suggested things like, you know, little videos in the GP in primary care waiting rooms and things like that. But obviously those are much more challenging. There's a pragmatic aspect here too, isn't there? Those can be quite challenging to produce. And I was wondering if you could talk to us a little bit about the production side of it. So you mentioned that you'd gone to a graphic designer. How did you identify that person or that service that produced them for you?
This work is actually in collaboration with the National Centre for Antimicrobial Stewardship. So that's a Centre of Research Excellence. So we've been doing a lot of work with them on just a whole body of work, program work on reducing inappropriate prescribing in general practice. So they actually had a graphic designer that does all their graphic work as well, but they're more heavily into the hospital-based side. So we actually said, okay, well, we'll try this graphic designer, and she just produced something that was really, really phenomenal. So we were quite taken of how easily she put things in and changed things as she went.
And how long did that sort of, I guess, producing those drafts take? Can you estimate a time frame there for us?
Actually, she was really, really quick. Her turnaround time might have been 1 to 2 weeks. You know, even with her heavy workload, her turnaround time was quick. And then we really only had minor updates throughout, even though from co-design 1 to 2. I mean, the only thing that, one of the few things that, you know, the participant critiqued on is they don't want to see the anatomy. So the first version had the lung for bronchitis. Oh no, that's too icky, you know, from the consumers. We don't want to see that. Okay, and then we thought, oh, by the time it gets to rhinosinusitis, we don't want to have snot or anything. So we thought, okay, no anatomy in that sense. So she's able to, you know, we gave her a bit of feedback, and she's able to tailor the graphic designing just from these feedback. So if you can see, there were consistent antibiotic pictures, but the treatment, like with UTI, the treatment graphic box was different to the treatment for, say, bronchitis or others as well. And then the pictures are slightly different. But the only thing that she told us, kept telling us, is, I can't fit all your words in, you have to cut it down. So that was the only demand she really had.
Okay. Ruby, another question from Penny here. What are some of the main challenges in the co-design process that you experienced?
booking a room was the main challenge. Just making sure that, you know, organise a time that worked for all your participants, because once again, you're not just juggling mums and dads, or juggling, you know, your GPs or your practice nurse. So that was really, that could be really challenging for anyone, really, not just co-design, but any type of focus group face-to-face, or even online, really, nowadays as well. I would really suggest that face-to-face, it's much better than a Zoom session, because a Zoom session, people talk over each other, then it makes it really, really challenging to work out what they want. The other aspects, I won't talk about challenges. I'll talk about what actually worked in the phase. It's actually, you have to have a scribe. So you record a session, and we recorded with the camera, as well as recording with the dictaphone as well. But you'll have a scribe just taking notes while you're there. And prepare. Everything has to be prepared, you know, in days before. You would actually run a PowerPoint type thing in the background, so all your participants are aware of the agenda, what they expect to do, and also the timekeeping. You don't want to make the sessions much longer than hour and a half to 2 hours, and you need to give them a bit of break in between as well. So we ran those sessions that were suitable to everyone, really, between 6 to 8 p.m. So that means also we had to feed them. So that wasn't really a challenge, or the only challenge is we never allocated money. So please allocate money to do that. And the other thing that made them really happy, well, not just make them happy, is we actually gave them a gift card per session that they were there as well. And they really appreciate that, because, you know, coming all the way to Melbourne Uni, you know, you still have to find parking, and then it's taken out of your, you know, dinner time, especially for the oldies, that they eat quite early. So things like that we have to be very mindful of. And really, they loved it. They loved the opportunity to provide input, especially the consumers. So I didn't really see any real challenges, as long as you prepare quite, you know, in advance, and also you have all the sessions booked. So we never had the second and third session booked, except at the end of the first session, and it was because all the participants said, let's book in the second and the third session now. And I'm going, what are we doing? So they were that enthusiastic and really keen to get these up and running.
And as far as tips and tricks for if we say developed some resources that we were keen to pilot in general practice, do you have any tips or tricks for the piloting process for us?
So what we did was we used the Vigrand network, but at the same, we used the Vigrand network. They were really good. The practices actually contacted us and say we're interested. Yeah. So I think the tips is you make sure the expectation, it's known to your participants and their practice, so they know what they're expected to do. So that's really, really important in any study, really, because otherwise, if they don't know what they're doing, they say, oh yeah, this is really interesting, and then they found out there was so much more work that they needed to do, then there's a high chance that your research may not go as well as you want it to go. You also have to have good relationship with these practices. So if, Sam, you were going to recruit practices within general practice, then you talk to our department and say, hey, how can we recruit these practices? And then we may, depending on, you know, your work and depending on how much work we think we're going to do. Now, having said that, the recruitment scene, it's pretty bad at the moment because of COVID, and all the practices are stressed about immunisation. So hopefully in the new year, it'll be a lot better for your recruitment. But I think you just need to be have that relationship with the practice. So even if we were to give you the practices that were interested, not give you, but we would say, you know, these practices are interested or whatever, you need to keep that relationship with them as an ongoing relationship.
And you mentioned the practice managers as being the gatekeepers as well earlier. Yeah.
So it's really hard to go directly to talk to your GP. You can actually leave them a message, but if the GP, if they don't know you, they're not likely to contact you. So if you get extremely friendly with your practice manager, then they're more likely to act as a research champion for you, and they'll poke the GPs and they'll ask them to do the, you know, whatever quality improvement work or whatever, you know, that they need to do, they'll make sure they'll get it done.
And Ruby, just finally, you have been quite recognised for this work, and I wondered if you wanted to share some of the recognition that you've garnered.
Yeah, so I put in the abstract for the AAA PC conference, which is our Australasia Association of Academic Primary Care. I think it's one of our biggest primary care conference nationally, and it was actually awarded the most distinguished paper award. And they actually asked me at the presentation then got bumped up to a plenary session, and we had a panel after that, and they were asking questions, and then they said, you know, how did you, you know, think you got the award? And I actually didn't know. So I think the way that they rated it was about research importance, how it translates into research. And I think because this project developed with the consumers in mind, or the end users in mind, and also being able to translate this research into practice, I think that was seen as really important. So any research you do, of course, you don't want to just do the research and then leave it to nowhere, but you want it to be able to translate it and be able to be used by health professionals and patients.
Yeah, well, congratulations on that recognition. Very well deserved, Ruby. And do we have any other questions before we let Ruby sign off? Last chance, anybody? No. And look, I'm sure, as we mentioned, Ruby, that we pop this up online, and we often get quite a lot of traction and views post session. So if we can perhaps provide an email and people can get in contact with you if they have any further questions, that would be excellent. Thank you. We've just got a great presentation. Thanks so much from Dan Gold, and likewise from me. So Ruby,
thank you.
Thanks again for coming along, and we look forward to keeping an eye on the next phases.
Thank you so much.
Thanks so much, Ruby. Bye-bye.